for those of us who are involved in implementing or analysing routine outcome measures data, often can encounter fairly negative views, and sometimes we can feel like the sort of pathological optimists in a fairly hostile environment. So, you know, William and Gladys Weasel are happy that they can go home knowing that everything is completely stuffed. Sometimes the clinical view, a common refrain from clinicians around data, is that the outcome measures really don't tell us much because the data quality is, well, poor. Criticisms are sometimes a little more sophisticated than that, and sometimes can come from more academic settings. And so, for example, Mike Slade has recently argued against the use of the HONOS as a measure for routine outcome measurement in mental health services on 4 grounds, really. Firstly, that it's really it's the wrong purpose. It's a public health measure being used for a clinical decision-making purpose. Secondly, that it reflects service priorities and not, such as aggression and so on, and not consumer priorities. Thirdly, that it's a clinician-rated measure and therefore less valid than a consumer-rated measure. And fourthly, that it focuses on deficits rather than recovery and well-being. So, and I'd like to come back later on to sort of perhaps look at some of those criticisms. But broadly, the aim of this presentation was to test some of those ideas and the extent to which some of those claims and concerns are true. And particularly just to examine our experience in New South Wales about how the HONOS and other measures are performing. In a sense, we've collectively released these measures out into the wild and into a sometimes hostile environment, and to try and see what data we can capture and see how they are looking, and to, are they like William and Gladys's specimens and completely stuffed, or are they still alive and kicking? In a sense, I'd also like to argue about this issue of data quality, and to say something which I imagine is probably fairly self-evident to this audience, which is that data quality issues are obviously not binary all or nothing problems. Data quality is always a dimension, and no data is perfect. All data contains a combination of signal and of noise. And the issue of whether data is good enough, it's certainly never perfect, is really dependent on the purpose or type of question and on the scale and statistical power of the work that's being done. And really, I would like to argue that our experience with the data has been that our current routine outcome data is usable. It's more than usable, it's valuable, and especially when considered in aggregate purposes, and is quite capable of helping us to understand meaningful variation between services, between people, in its current form. This presentation is really not at all addressing issues of individual clinical care. So a number of people can argue better on that issue. Tim and Rod McKay have written about the use of the HONOS in an older person's service. Michael Lambert has demonstrated some of the effects of feedback in individual clinical care. And Andrew Page and colleagues at Perth Clinic have done some interesting work on integrating simple outcome measures into information systems. But our experience as a team is really on the aggregate use of the measures, and looking at differences between groups of between services and groups of consumers. I'd like to come back later to that issue of whether those aggregate uses might actually be sufficient to justify the ongoing use of these services, these measures. Now, talking about data quality as if it's even a single dimension is obviously also a simplification. Our data should be expected to meet the same standards of quality that all other data should meet. It should be reliable. It should be free from errors of measurement and variation between raters or over time. It should be valid. It should have face validity. It should measure something plausible. It should have construct validity, tapping into a meaningful underlying construct. Concurrent validity, aligning with other data. Other measures, predictive validity in terms of helping us predict things, important outcomes, and incremental validity in the sense of adding value to and providing information that's not provided through other measures. It should be sensitive to both meaningful clinical issues and to change over time. It should only measure what it sets out to measure, and it should be, as far as possible, representative and not biased in terms of the information it collects or in terms of selection on basis of people or services. A lot, but not all of those measures can be moderated by the effects of scale and size and power. And let's come back later to that sense of which of these issues are more or less influenced by scale. Our experience with these measures needs to be set against the broader literature, obviously. A recent review by Delafon, again looking at the HONOS, gave a sort of mixed review of the measure, highlighted that the HONOS has been widely used in service evaluation around the world, especially in the UK and in our two countries, and especially in community and rehabilitation settings. But certainly over the last decade, there have been a large number of papers that have looked at the HONOS in large scale and in routine use, and found that it seems to perform reasonably well. So the HONOS has demonstrated clinical utility in discharge planning and communication, in early psychosis services in Italy, in routine clinical use in Canada. It's demonstrated sensitivity to change in settings that include psychiatric services, forensic services, assertive community care and rehabilitation. Shown to predict outcomes in early psychosis. A recent study there by Hayes found that the HONOS ADL subscale score, ADL item score was one of the stronger predictors of mortality over 4 years in people with serious mental illness. And predicts service use in community care and in special populations including homeless people, frequent service users and people with substance comorbidities. Of course, not all of the findings are positive, and a number of studies have found difficulties with inter-rater reliability. The Hunter study, the Scottish Schizophrenia Outcome Study, found poor sensitivity to change for the HONOS, and the Duke study there looks at consultation liaison and found limited sensitivity to change in that setting. Now, the HONOS has been the most widely studied measure, but the LSP has also been shown to demonstrate concurrent and predictive validity. The last study there used baseline LSP scores and found them to be a strong predictor of changes in grey matter volume on magnetic resonance spectroscopy, for example. And a recent RAND expert panel review looked at potential measures of social function for routine use and recommended the LSP as one of half a dozen or so measures that might be suitable. So to turn then to New South Wales data, and just to give an overview of the data that I'll sort of walk through. So firstly, to start with the HONOS and looking at the HONOS and comparing services and then comparing programs and settings and some clinical groups. To look at some other measures, the LSP, the K10, and a local measure, the Activity and Participation Questionnaire, and then come back to the HONOS to look at questions of predictive validity, particularly around readmission, and then to finish by talking about some of the challenges, and especially the issue about selection bias in who we're measuring. First then to look at the HONOS and differences between units. So we've, in New South Wales, had a clinical benchmarking program for a number of years, and part of that involves providing aggregated 6-month data to units, allowing them to compare to peer groups. And that includes HONOS, an admission profile and a discharge profile, which I'll show you in a moment, and also change groups using the national KPI specs. And we've recently added the K10 to that data. So this slide shows the HONOS admission profile. This is from July to December last year, and this is for the adult acute peer group, 47 units in that group. And what it's showing across the x-axis are the individual HONOS subscale scores, and on the y-axis, the percentage of episodes in each unit that have clinically significant scores, 2 or above. And this is showing the distribution for those 47 units. So the green line is the median for those units, and the upper and lower grey lines are the 25th and 75th percentiles. So 50% of units fall within those grey lines. And certainly that profile has been very consistent over time. It's always pleasantly surprising to us how narrow those ranges are, how consistent the scoring is between services. And certainly looking at the web-based DST on the national data, it's very consistent with the national data also. While most units are very consistent, there are outlier units, and the other finding has been that where the scores do differ, that does seem to be tapping into meaningful difference between units. So for example, so here we see the data for one unit shown in the blue bars overlaid over that peer group average. So here we have a unit with high rates of clinically significant substance use and depression scores, and also slightly higher rates on some of the functional measures. This is a regional unit with high rates of disadvantage, many young people, and high rates of comorbidity. Perhaps a more striking example is this unit. This is an inner city unit, very high acuity, very high population of people with serious mental illness, homelessness and disadvantage. And we can see that this unit really is an outlier, much higher rates of clinically significant psychotic symptoms and substance use, lower rates of mood disorder. Now that makes sense, but arguably you could get that information looking at the diagnostic profile from those units. What's interesting about the profile is that it also provides us information that you can't get from diagnosis. So high rates of overactivity and aggression, and interestingly here, much higher rates on the functional measures, ADL, living conditions, occupation. And certainly our experience in feeding back these measures has been that it had high face validity with services, that people do feel that on the whole they capture meaningful variation and they describe their services well, and that particularly being able to capture some of that additional information that's not captured elsewhere is seen of interest and of value. This slide's making the point that it's not only the admission profile that's of interest, but the discharge profile as well. So this shows, again, HONOS subscale scores, percent significant, but this is looking at the discharge HONOS. The scores, thankfully, are all lower, again, reasonably consistent across the state. This is an outer metropolitan unit with very high rates of youth disadvantage and unemployment, and it's interesting to see that for this service, clinicians are rating nearly 40% of people as having clinically significant substance use problems, and nearly 70% of people as having clinically significant occupation problems at discharge. It's easy to see how that sort of information could be relevant for clinical planning and service planning. So that's about difference between services. But now I want to just talk about the issue about differences between programs and settings. So this slide shows the HONOS admission profile for two different peer groups. The adult acute peer group is shown in orange. So that's essentially the same data that we've just been looking at. Here it's the average for all of that group pooled rather than the median for the units, but it's a pretty consistent story. And the blue line is the psychiatric intensive care unit and HDU, the higher acuity services. So we can see there's a lot of similarities, and on the core symptoms of psychosis and depression, not a substantial difference, but where there is a substantial difference is in overactivity and aggression, and also in substance use. Again, that might seem self-evident, but it is partly capturing some information that's not otherwise captured by diagnostic information alone. And that point could perhaps be made more clearly looking at comparing inpatient and community diagnoses, data. So here we've got the diagnostic profile for our acute inpatient units for a recent 6-month benchmarking period. The most common diagnoses: psychosis, depression, anxiety disorders and adjustment disorders. Out here, about 10% of acute inpatients have a primary diagnosis that's not an ICD-F code, and that's particularly, some of those are medical conditions, some of those are codes for self-harm and self-injury and so on. The red line is the community diagnosis, and this is looking at the last diagnosis per person seen in the community. Really, there's no difference. There's some minor differences in the ratios of psychosis and mood disorder, but essentially the same curve. If we look at the HONOS profile, here we've got that familiar admission profile for admission to inpatient units, and here we have the profile for the community. Now, this is the first HONOS in the period for each person, so it's a mix of review and admission. There are much more differences in that profile than there are in the diagnostic information. So differences in symptoms, psychosis and depression, differences in some of these clinical issues around overactivity and self-injury, and perhaps slightly higher on some of the functional problems. So that the HONOS is capturing information about differences between people and over time in ways that the diagnostic information is not capturing here. Perhaps just, I think it's interesting too that we're often accused as services of being very illness-focused, very symptom-focused. It's interesting that this is a clinician-rated measure, so clinicians are rating community clients as having relationship difficulties about twice as often as they're rating them as having clinically significant psychotic symptoms. We've also found that the outcome measures have been interesting and seem to add value when we're looking at clinically important groups of and subgroups of people. So we've recently been looking at data on people with a diagnosis of personality disorder. I probably don't need to, spell out the rationale, but personality disorder, clearly is an issue that has major impact for individuals, for their families, for services. On our inpatient data, around 15 to 20% of people have either a primary or an additional diagnosis of personality disorder. Most of that's borderline personality disorder. And most of the reviews of prevalence of personality disorder would suggest that that's a significant underestimate. But we were interested in looking at whether those routine outcome measures could add any value to our understanding of those conditions. So again, looking at the HONOS, we looked at HONOS for people admitted to adult acute units over 5 years with no personality disorder compared to either a primary or comorbid diagnosis of personality disorder. Total HONOS score, people with a personality disorder diagnosis had a slightly higher overall HONOS score. It was significantly different, but only a slight total difference. But the profile tells, again, a meaningful story about the difference between the types of clinical problems that we're encountering. In looking at personality disorders, it's also an opportunity to talk about some of the other measures. We're interested in looking at the K10, the Kessler-10. It's a 10-item consumer-rated measure. It yields an overall score and a score which allows you to be put into bands by level of distress. So we looked at K10 at admission for adults in acute units. Because the K10's only been added to our data more recently, we're just looking at 6 months of data here rather than the 5 years of the previous slide. And we found, pleasantly surprised to find that around a third had a consumer-rated measure at admission. A third might seem like not much, but it's better than we might have hoped. The K10 consumer-rated measure told the same story as the clinician-rated measure, really, which is that people with a personality disorder rated themselves as having higher levels of psychological distress at admission than people without, and people with a primary personality disorder diagnosis scored slightly higher than people with comorbid diagnoses. This shows the K10 admission data, but grouped in those bands using the K10's banding. So people without a primary personality disorder diagnosis, without any personality disorder diagnosis, around a half rated themselves in the most severely distressed category, whereas over 80% of people with a primary personality disorder diagnosis. Now, so far, we haven't really looked at the issue of sensitivity to change. And we did look at K10 and some other measures at admission and at discharge. So again, for that same period, we had the numbers here do definitely start to get smaller. So we had about 15% of people had a pair of K10s both at admission and discharge from the admission. And there were some slight differences in completion rate between the groups. But with those caveats, there's the admission profile. And here's the K10 scores at discharge. Everyone got better by their own rating, but people with personality disorders rated themselves, improved proportionally slightly less and rated themselves as significantly more distressed at discharge. I'd like to go on and just briefly discuss some other measures and some issues of concurrent validity before coming back to the questions of predictive validity and the HONOS again. So one of the big gaps in our measurement agenda nationally has been in issues, broader issues, aspects of recovery, the social aspects of participation in work, study and social activities. And in New South Wales, we've developed and implemented a measure called the Activity and Participation Questionnaire, or APQ. And it measures, it's a brief consumer-rated measure, and it's still early days in a sense. It's been rolled out as an opt-in measure with a sort of fairly slow launch, but has had some take-up in especially rehabilitation and early psychosis services. And so we're interested to see to what extent the NOC measures could be used to validate the APQ and perhaps vice versa. So this slide shows the relationship between the consumer-rated employment status on the APQ and the clinician-rated view, which is the work capacity item of the LSP. The questions of the APQ are used to allocate one of those standard employment statistics, employed looking or not participating. And you can see that the two tell a very consistent story, that the LSP rates in a negative direction in a sense, so that high scores on the LSP mean the clinician views the person as having high levels of difficulty in that regard. And so, nearly 80% of people who clinicians rated as having low work problems were either working or looking for work, whereas nearly everyone who the clinicians rated as having work-related problems were not participating in the workforce. It's not surprising, but it's certainly reassuring. Here's the HONOS subscale, the HONOS item of occupation and activity compared to the LSP. That item is less specifically worded to be about work than the corresponding LSP item, and the relationship is slightly less striking, but still very consistent and still in the same direction. What about social activity? The APQ asks people to list the number of social activities that they participate in. There's a sort of menu of types of activity, and so this just counts the number of activities. So here we've got the number of social activities. Very few people reported 7 social activities over. The APQ measures over the preceding week. So people with high scores on the LSP social withdrawal subscale reported much lower rates of social activity. They're all subscales. What about total? And there's certainly a whole question about, is it valid and possible to have an overall measure of social participation, or are they all separate things? But we have done some preliminary work trying to look at a scoring system for the overall APQ, and one simple approach is just to, for each of these 4 domains, give a score from 0 to 2, giving a maximum possible score of 8. Now, in fact, very few people score 8, so we've collapsed those higher scores. So we've got a score from 0 to 7 as a total participation score, if you like. This shows the relationship between the 2 consumer-rated measures, between the K10 and the APQ. And there is, again, that clear relationship. People who are rating themselves as involved in more work and social participation overall also rate themselves as having lower levels of psychological distress. Pretty clear in those lower levels. It's less clear at those higher levels, and is that a data problem, or is that these people are just working and studying too much? Perhaps this is where everyone in the room would rate themselves up here. And again, a very consistent picture with the LSP, with people having high rates of overall participation in work and study and social activity, scoring much lower on the LSP. We set out to, in a sense, use the NOC measures to validate the APQ, and in that sense they do, but in another way, the APQ being rated by the consumer also indirectly validates those NOC measures. And it's interesting and reassuring to see that those consumer-rated measures of employment and study and social participation do seem to correlate very clearly and very well with the clinician-rated measures of corresponding things. I wanted to return to the HONOS and just give 2 examples that address issue predictive validity and where the HONOS seems to add to our ability to predict outcomes. And both involve readmission, but over different periods. So the first is looking at 28-day readmission. It may have been well promoted above its level of competence, this as a KPI, but it's definitely the most widely reported and scrutinised KPI of the Australian KPI set. And it's clearly very likely that a whole range of factors contribute to readmission rates, some of which are in the control of the services and some are not. And they're likely to include factors in the person, factors in their illness, factors in the episode of care, both inpatient and community, and so on. So this is showing the results of logistic regressions, binary logistic regression, looking at predictors of outcome for 5 years' worth of data, adult acute admissions, trimming off above the 95th percentile of length of stay, which is about 52 days. The odds ratio, if this is below 1, that means that it's associated with a reduced risk, and if it's above 1, it's an increased risk, and the confidence intervals are here. And for things like age and length of stay, each change in the odds ratio reflects a change of 1 unit. So this is saying that for each extra year of age, there's about a 1% less chance of readmission. And so we can see that a number of person factors predict readmission. So readmission is less likely with increasing age, less likely for men, more likely for people who are homeless and more likely for people who are out of area, and less likely as length of stay gets longer. What about diagnostic-related factors? Slightly more likely for people with psychosis, less likely for mood disorder, substantially more likely for personality disorder. All of these are statistically significant findings, and one of the issues with very large data sets is, even small differences can be statistically significant. But to me, one of the striking things here is how modest most of those associations are. They're not really big. And certainly, length of stay, age, gender, and so on didn't have really a very substantial impact. The issues about homelessness, well, that's plausible. being admitted out of area has a strikingly high impact, and personality disorder, which is consistent with some other data we have. Can the HONOS add value to that? This looks at the HONOS change scores for people, and the comparison group here is people with no HONOS measured. So, and what that shows is interesting both in its direction and its magnitude, I think. So people whose HONOS improved, even after controlling for all of these other personal and diagnostic factors, people whose HONOS score improved were nearly 20% less likely to be readmitted, and people whose HONOS score deteriorated over the stay were more than 20% more likely to be readmitted. So, in a sense, you know, the HONOS here adds some value to this interesting clinical picture. That's readmission over 28 days. Readmission over a longer period. I'm quite interested in the issue of substance use and first episode psychosis, and one of the things we were wanting to do was look at the relationship between ongoing substance use and first episode psychosis. So we've got data on around 7,000 young people aged 15 to 30 who've had their first ever admission to a New South Wales mental health unit, and for whom we've got data over at least 2 years. Now, for around 2,000 of those, that first ever admission was the only contact we've had, and in the subsequent 2 years, we don't know what happened. They haven't had community follow-up from us. Not a great number. And they haven't had other mental health readmissions or other admissions to New South Wales hospitals. So we know they weren't readmitted, but we don't know much else. But there's another group of about 5,000 where we do have data on their ongoing care over the subsequent 2 years. And we've got data from their community mental health data and also from general hospital admissions. And so where people have been admitted for other reasons, we can look at their care. And so with those two sources of data, it's possible to derive a sort of a proxy measure of substance use, ongoing substance use. So where people have got substance-related diagnoses in their ongoing data or clinically significant subscale, clinically significant scores on the substance use subscale, then we can assume that they've got ongoing substance use problems. And within this data, the HONOS does quite a bit of a lifting because the comorbidity data, especially in general hospital data and also in the community mental health data, is often a bit incomplete. So of this group of about 5,000, just over half were readmitted within 2 years and just under weren't. So this shows the survival curves for time to readmission for 3 groups of people broken up based on their baseline and their ongoing drug use. So people who had no drug use at any point, around half were readmitted at 2 years. But ongoing drug use had a very major impact on readmission. So the best outcomes were for people who had drug use at their index admission and no drug use in their ongoing care. So if drug use triggered your first psychosis and you stop using drugs, you have a good outcome. It's a really important clinical message. On the other hand, the worst thing you can do is have drug use at baseline and keep using drugs. And that group had a much higher, 2/3 were readmitted. The issue here is that the HONOS, added with other clinical information, did seem to provide us with some predictive information on a really important clinical issue. To summarise, we've seen that the HONOS profile seems to give us consistent and plausible profile differences between services, meaningful variation for outlying services, and to capture differences between service groups and settings in ways that aren't captured by diagnostic differences. Both the HONOS and the K10 seem to reflect differences in profile, in distress and in change in people with personality disorder, but there was good correlation between consumer and clinician ratings on issues of employment, study, social participation and so on between LSP, K10 and HONOS, and that the HONOS adds some predictive value. So in a sense, the measures do have some utility, some validity, in a number of areas, and sensitivity to things that are important. In another way, we've set our nets and captured some data and dragged it back from the wild, and our sense is that unlike William and Gladys's fox, they do seem to be alive and kicking, some of this data. I wanted to come back to Mike Slade's critique because my sense is that certainly our experience of the data is that Slade sets up 4 dichotomies in his argument. And I wonder whether that's just too black and white. So this idea that a measure can either be a public health measure or a clinical decision-making measure. So I'll leave the individual clinical arguments to Rod and Tim and others, but our sense of the measures is they do appear to have clinical relevance, sensitivity to important clinical issues, sensitivity to change. So, those are some of the attributes you do need in a clinical measure. The idea that the HONOS and other measures are really all about service priorities and not about consumer priorities. Well, I think when we look more broadly at the measures, they do seem to tap into issues that are arguably shared priorities, things like distress, things like social outcomes and work and so on. The question of consumer-rated versus clinician-rated, really, of course, they don't tell exactly the same story, and you wouldn't want them to. But there does seem, in our routine data, incomplete as it is, to be quite meaningful and complementary relationships between the consumer-rated perspective and the clinician-rated perspective. And on that issue of deficit or recovery focus, well, even our current measures, they may need a bit of modernising and a bit of changing, but even in their current form, they certainly seem to be able to touch on issues of work, social participation, study, relationships in ways that do make sense. Coming back also to that question of data quality, as I said, I think our experience of these measures is that as used out there in routine practice, they do have some of the properties of good enough data. From our point of view, perhaps looking at data at a state level, we're a bit helped by scale, and because data precision is partly relative to scale. And here we're looking at data that ranges from dozens of measures in looking at individual services up to to tens of thousands of measures looking across the state or across time. And in aggregate use, size does matter. Size matters especially for non-systematic variation, where there's noise, where there's just random variation in the data. Large data sets very quickly get rid of that, and the signal very, very easily emerges from the noise. And we can see this, mostly here we're not presenting statistical analysis, but certainly as sample sizes increase, the robustness of statistical tests to violations of their assumptions increases. So for some statistical tests, 50 to 100 is large enough, and certainly there's some interesting modelling looking at public health data sets that once the sample size gets above about 500, that even very substantial violations of assumptions, skewness, kurtosis and so on really have very little effect on statistical analyses. There are still, of course, many, many challenges in looking at this data. So now many of them are challenges outside the measures. The recent NOC review and the consultations that Tim and Sarah have done on that really highlight that many of the challenges of capacity, of resources, of reporting, of leadership, of training and so on. But there are still many issues to address within the measures. There's the issue of zero scoring or invalid or under-rating, and the issue of potential systematic underscoring in some areas. And then there's a question of quantity rather than quality, and the fact that collections are still incomplete, and that therefore introduces the possibility of very systematic selection bias in who's being measured at a person or a service level. This shows the HONOS completion rates for our units for the most, this is adult acute units again, for the most recent 6-month period. Basically, around 80% of our, so the median score for our acute units is that around 80% of people have a HONOS measure during an episode, around 60% at admission or a discharge, and dropping down to around 40% for an admission-discharge pair. So obviously, if we're looking at admission and discharge profiles or looking at change, the possibility of real selection bias is potentially concerning. So we're interested to look at, well, what are the predictors of having a HONOS pair? And this is, again, binary logistic regression, just looking at that presence or absence of a pair over 5 years of data. Same data set as before with the trimmed length of stay. And again, and this is just showing that the significant associations. So age, yes, slightly older people are more likely to have a HONOS pair. Mood disorder, slightly more likely. Substance disorder, slightly more likely. Length of stay, slightly more likely. The most, again, statistically significant, but on the whole, these are really tiny effects. The only effect that's really, looks meaningful in there is that issue about people born outside Australia being nearly 20% less likely to have a HONOS pair. I was surprised. I'd expected that length of stay would be a big driver here. That, the shorter duration would be, and that the longer you went, the much more likely you would be to have a pair. But in fact, yes, it's related, but only just. So, 0.2% increased likelihood for every extra day in hospital. This is showing the percentage completion of a percentage with a HONOS pair broken down by length of stay. And really that week positive association is about what's happening in those first 3 weeks, where 75% of people are in those 3 bars. But it's not very striking, is it? Even people that are staying less than 7 days. So it's almost as if when units are doing a HONOS, they're doing a pair. So the person factors and the episode factors don't seem to make a lot of difference, but the service factors clearly make a lot of difference. So this shows the percentage of episodes with a HONOS pair counting our acute units. So we've got a sort of a distribution there with a number of services having 70, even above 80% of episodes having a pair. But we've got this sizable tail where there's less than 20 or even less than 10% of episodes have a pair. Exploring some of that in benchmarking, there is the sort of mix of factors that you might expect contributing to that. There are information systems issues, there are resources and workforce issues, but also clearly there's culture and leadership issues. And certainly a number of those services are places where local leadership, especially local medical leadership, has a very strongly negative view. Why should we persist with these measures? And in the current Australian climate, that question of should we persist with these measures and why these measures is likely to be asked. And I think the answer then partly, our sense, the lessons from our looking at the data, that the answer may partly depend on the different stakeholders who are asking the question. So for consumers, I might argue that really, obviously, development of these measures is needed. They do need more work, they do need refinement, but even in their current form, they do seem to be able to tap into meaningful issues and add some meaning to issues. For clinicians, I think one of the important messages is that the data is capable of being used and is being used, and that there is a value in that. And in that sense, coming back to that issue versus individual versus collective use, collective uses, I think, are okay. And as a clinician, I would say I don't think that clinicians demand that everything we collect has absolute clinical meaning in every interaction. I think what's most offensive to clinicians is often the sense that we collect things and it goes nowhere, it disappears. And certainly our experience in feeding back the data to people is people are very interested, very engaged, and with the idea that it's being looked at, and used to understand differences between their service and others. People aren't demanding of us that, show us how this helps me with this individual person that I'm seeing. They're energised by the idea that collective use is there. And certainly, while I don't think as clinicians we demand that every item of data is clinically relevant for each individual encounter, I do think we demand and have a right to demand that the time and effort that goes into collection is sort of proportional to the value of the data and then the uses of the data. What about clinical leaders, policymakers, funders? In my experience, often this has been some of the group with the most black and white views of this data. And I think here that message that the binary view of quality may be too simplistic, that our very substantial investment in Australia and New Zealand in these measures has produced some returns, it does produce meaningful data, but that the timelines, the return on investment is incredibly slow. Look, there's also another really critical group of stakeholders here, which is the broader community, the broader set of organisations scrutinising our mental health system. And one of the sort of current refrains, certainly in the Australian context, is, okay, we might be measuring things, but we're measuring the wrong things. Our experience with these measures is, again, that might be just a little too black and white, that these measures do seem to be able to touch on some important aspects of experience, of function, of work, of relationships, and so on. And they are getting into the territory of recovery. They're not rich recovery measures, but they are certainly tapping into those dimensions. Also, in that context, one of the important questions is the comparative set of questions. How do we know whether Australia's services are better or worse than New Zealand's or Canada's or Sweden's? How can we compare health systems? How can we compare different types of providers? Well, in some ways, some of the weakness of the measure, some of the bluntness, some of that sort of sense that they're just trying to be a one-size-fits-all measure is actually also some of their strengths. That the measures are broad, they're universal. They can provide a bit of a common currency that allows some comparison across very different settings. Returning for the last time to Michael Slade, he proposes an alternative to the HONOS, the approach they've taken with the OCAN, where it's bottom-up, a lot of rich local consultation, local measurement development. And you can see the appeal of that, but that obviously makes it very difficult to answer those types of questions. I've been given the red card by the chair, so I'll just finish with the last slide, which is to say, our current measures are clearly neither the road to salvation, but nor are they the road to perdition. They're They're tools. Our experience has been that they're useful tools. And like all useful tools, they've got limitations. They're used particularly for us in that collective and aggregate analysis where the scale can overcome some of the data quality problems. I'll finish there. Thanks.